I'm not sure if I'd like it, but anyway, I'm sure you're very happy.
Yeah, they're lovely. They're really snug and warm.
Very good. Okay, so welcome everybody to this meeting in public of the Worcestershire Acute Hospitals NHS Trust. I've got apologies from Wakar and Sharon. Anybody else? Rebecca? No?
Chair.
Okay, thank you. Thank you for that. So, at the beginning of every board meeting, we try to have a story about what's actually happening in terms of the services that we currently provide. It's an important way in which the board can start its conversation off about the reality of the world that we exist in, and some particular individual story is always really important for us to understand what's happening, and it has the added effect of sort of grounding our discussion. So with that, can I welcome Amy and Ross this morning, who are going to talk to us about a particular individual. So can I hand it over to Paula, who's going to introduce the item?
Thank you, Chair, and good morning, everybody. And very welcome to Ross and Amy. Amy and I had a lovely chat yesterday. So the running order will be that I'll introduce Ross, who will then introduce the story, which is, it's always hard coming into hospital, but it's even harder when you've got issues that you need and challenges that you need to deal with to enable that sort of safe, swift visit that enables people to feel that they are safe during their journey through our organisation. And Amy is the carer, and she will talk about her particular story with regards to, we'll call the patient P. So without further ado, I will hand over to Ross, who will take us through this story. So thanks, Ross.
Thank you, Paula. Yeah, good morning. So hello, everyone. My name's Ross Golightly, and I am one of the Learning Disability Acute Liaison Nurses in Trust currently. When I was asked by Anna to consider a patient story, this person jumped into my mind immediately, and I think that will become quite clear as to why shortly. And I'm very fortunate to have had Amy on board when I approached Amy to be a part of this as well, so thanks, Amy, for that. I've been in this post for 5 years next month, and the reason I say that is because I think I can say with relative certainty that this is somebody that's probably required the most complex support to simply bring into hospital at almost all stages. So various stages before the admission, or whether it's an inpatient admission or an outpatient attendance, of which there's been both for this particular person, during the admission as well, or during the appointment. This is somebody that I need to liaise with Amy quite frequently about. So if Amy gets a letter for this person, or you get a call, you often will be on the phone to me quite quickly and say, this is what's happening, this is the date, we need to kind of get a plan together, and then we will liaise with the clinical department, wherever that will be, whether we've had appointments at Worcester predominantly, but also at Kidderminster site as well. And I'm sure Amy will talk about this when she speaks herself, but Amy often will now go on site to do a risk assessment of the environment to see how suitable the environment is to bring this person for an appointment, and to liaise with the clinical teams there directly to see, to sort of suggest what reasonable adjustments this person will need to make the appointment work successfully, whether that's simple changes to do with the lighting in the area, the physical space, or the amount of chairs, the amount of clinical equipment in the area. And then we'll get we aim to then get a safe plan in place to make that appointment work, and we kind of all coordinate it together and hope that it's kind of a cohesive plan on the day. For some people that I've supported, there have been similar complexities to this, but it has been the case where there have been tiny hiccups and we've been able to work with that. But I think for this person that we do have to insist that it goes as according to plan as possible. I think that would then present quite significant risks to this individual, or to the staff team, or to other patients as well. So it is quite important that everyone is really clear on this plan, and that it is followed through as close to the letter as possible. So Amy, did you have a particular kind of admission in mind that you wanted to talk about today, or did you think collectively we just wanted to talk about what the normal steps are for when we bring this person into hospital?
I think all of them. To start with, he's the most remarkable young man.
Yes.
Not as daunting as he sounds on paper, but I think all of them have been we've been so well supported by you in particular, Ross. I can read out the testimonial if that's easier that I did, and then we can talk more.
Sure. If everyone's okay. Yeah. Thank you, Amy. Yeah.
So what I wrote was, we are extremely grateful for the support that the LD team have offered us in regards with P's needs, especially Ross. If we hadn't have received such support from Ross, then we wouldn't have been able to help P with appointments such as hospital admissions, general appointments, x-rays, scans, general anaesthetics, all over the last 2 years. P experiences sensory processing overload that can fluctuate throughout the day depending on mood, activities and environment. P has difficulties with self-regulation and often needs time and space in an area to process. P is non-verbal and can express challenged behaviours which will challenge us. P attends the hospital 5-1. He attends in a wheelchair with a Houdini harness. P finds transitions particularly challenging. Ross always ensures we have parking available outside the hospital to ensure the shortest and least overwhelming transition for P. Ross took his time to get to know P and his staffing team. He saw our passion and how important and vital it was that P was understood and his processing and sensory needs were met. Ross has always been available to go through the requirements needed for the day after the environment has been risk assessed. For the difficult appointments, such as general anaesthetics, Ross has met with P's manager and key worker to do the risk assessments with us, to understand what's required for the day, how the environment needs to be set up. Ross has always ensured staff are aware of P's appointments, needs to ensure the environment is safe for P, staff and public. Ross always ensures the lights are lowered, the environment's ready to prevent P from getting overwhelmed. Ross meets us at the car and supports us, ensuring the hallways are cleared, the doors are open for a smooth transition. The support we've received from the LD team and Ross in particular has enabled P to receive the treatment he requires in a safe, understanding environment. We're forever grateful for the support we've received from Ross and the LD team.
Thank you for that, Amy. I think it's also really important to highlight as well that I think the staff teams as well that we've approached this have also been really accommodating, haven't they? So think about the teams that Nathan P had many appointments at Larkspur, and often, I can't think of. I think there was one time there was a slight ticket, wasn't there, with the room not being quite ready. But other than that, it has always gone swimmingly.
In that situation, they understood, and they managed to revert and get everything sorted very quickly, and he managed to stay calm. And it's a difficult environment because no talking can be done in the room. It all needs to be done outside. He does need to be in a safe clinical hold, so everything that needs to be done and the positions he needs to be in needs to be discussed in length outside of the room. And then the staff team, we just communicate almost through our body language of how he needs to be and where he needs to be placed. And touch wood, we have never had an issue at the hospital, and he's gone through everything he needs, and that even includes a CT scan, which we were amazed with at Kidderminster. That is purely because we've had such great support while we've been there.
I think one thing I take away from this, I think it's unusual for a fair majority of the people that a lot of the teams see wouldn't need this volume of simply coming with 5 staff. I can't think of anyone else that's come. I think we have a lot of people that come 2 to 1, but not more than that. So I think it's an unusual situation for the staff in the hospital to face. But they've taken it on, and they listen. They perhaps may not understand why it's needed to the full extent, but they have always accepted it and worked with us to make it happen. And thanks, Paula. Thank you.
Paula.
Thank you, Chair, and thank you, Ross and Amy. That was, that's really heartfelt what you've said with regards to how we've made sure the environment is safe for P, and that the staff are aware, and that the carers that come with him. It looks like a whole multidisciplinary team effort, of which I'm really proud of, from your end to our end and back again. So I think, Chair, if it's okay with you, if you want to open this to questions now.
Fine, thank you very much. Thanks, Amy. Thanks, Ross. Anita.
Thank you, Chair, and thank you, Amy and Ross. That was really lovely to hear, and it sounds like it has been absolutely a team effort. I had a question, really. Something that I'm aware of from my personal experience is that with people with learning difficulties or indeed dementia, over the last couple of years with lockdowns and things, that appears to have exacerbated challenges for some individuals, and it's also exacerbated sometimes the decline with dementia. Are we finding that it sounds like it was it's a phenomenal effort that's put together for patient P. I'm wondering whether those kinds of the level of adjustments that we're having to make are getting worse, and have you noticed that there's been any kind of impact over the last couple of years?
It's difficult to say for dementia. Obviously there is an overlap where lots of people with learning disabilities do have a diagnosis of dementia as well. In terms of learning disability, nothing to this extent. In terms of the amount of adjustments at every stage I've worked with before, in this role at least. I'm not sure of a relationship between the various lockdowns. I mean, absolutely, lockdown has from simply like visiting. Perhaps there's been issues with visiting, and care homes not being able to come in because they can't sustain the staffing on their own rota, so they wouldn't bring the staff in they usually would. That's naturally affected how we provide care, because we perhaps wouldn't have support for that person as they usually would if they were in their own home. Other than that, I don't think there's a direct relationship between the impact of adjustments. I think training is important, and that's one thing I was going to get onto. I think training has been difficult because naturally the COVID situation has affected how we deliver training and how often we can do it and who we can reach. And within my clinical capacity, we're normally in a team of 2, but I've been on my own for almost a year next month, so it's been difficult to directly facilitate that. But I do, when I do deliver training, I really do, ask staff to take away the kind of if they take one thing away, I always say make sure it's the idea of reasonable adjustments. And it's not always the same kind of textbook examples of use of side rooms, use of easy read information. It can be anything that can make that kind of pathway for that person easier. I think we are getting there. I think sometimes people don't even know they're doing it. They're not thinking, I'm doing a reasonable adjustment here. It's just part of their innate practice. They're probably doing hundreds a day and they're not even aware of it. I think that's pretty good.
Ross, just to ask a couple of questions I'd like to ask. First of all, Amy, can I thank you at the beginning you said what a wonderful individual this person was, and often when you get into the debate around this, you're so focused on the problems of the individual, you forget that they are a proper real individual with and it's fantastic to hear that. There are a couple of things for me. One of them is, I'm assuming that you've been talking about his interaction with the hospital around planned care, elective. What would happen if he had an acute problem?
Oh, Amy, that was the very first admission, wasn't it, when we first became aware of it?
The first time we came was an ambulance hospital admission straight into A&E. We were going in blind. We'd never taken him to any form of appointment. We were straight into A&E. They assessed our needs immediately. They found us a room. They put us in a room, so we were out of the lights. We could have a low arousal environment. It was quiet. They understood that all conversations needed to be outside, and we were really, really well looked after. He was in distress, and he was very, very anxious and scared. But they allowed us to stay with him, and they listened to us. They understood and they saw the situation. So, they put us in a safe space immediately, which was the most important thing. And from that day to how he is now, we get smiles, we get happy hand motions because everything from day one has gone right, and that is because of the support from the hospital.
That is fantastic to hear. I mean, that is really good to hear, because you can never guarantee that the emergency will be the same as the plan, but that's fantastic. And then our second one is, if we were a bit more radical, could we provide more of the services that he needs in his own place of residence?
I think so. I think he's needed a lot of like x-rays, and he needed surgery and a lot of scans. So I think it would depend on what needs to be brought to him. He's coped so well. I think he's absolutely fine doing the transitions to the hospital. But if there was a situation where we couldn't get him to the hospital, that's definitely something that would probably need to be discussed.
Yeah. Okay, thank you. Any other questions people got? Simon?
One for Ross, actually, but thanks to Amy as well for the story. Ross, are the things that would help sort of your working balance, how you are sort of staffed and equipped, are the things that we ought to be aware of as a board that maybe your section would benefit from? Because it's a great story and I've really enjoyed hearing it. I'm always interested in, can we do things a little bit better, and sometimes it's best just to ask straightforward the person who's on the sharp end.
I think obviously my gut thought is recruitment, but that is being resolved. That has naturally impacted the level of service I can provide, because we're normally a team of 2. As I said, I've been on my own for almost a year, but we have a new starter coming imminently, which I'm very, very excited about. And then that will naturally affect. We'll be able to be a bit more. It'll feel less like it's all on my shoulders then. I think one of the good things is to go back to training again, because it is so important. I can't really underestimate the importance of this. I think right now the training I do is training that I devise myself. I don't know if the hospitals down in Birmingham or Coventry or anywhere else are getting the same kind of level of training if it's done in the same way. But I think what's happening shortly is that all training will be standardised across the whole country for the whole and health and social care economy. So I don't know I know, Paula, you're aware of Oliver McGowan, aren't you? Some of you will be aware as well.
Yes.
This is a gentleman that died a few years ago with a learning disability and autism in the southwest of the country. His family campaigned for mandatory training in learning disabilities and autism. That was passed in 2018. And that's for not just the NHS, but the private sector as well, and all clinical roles. So right now I do training, but it's not mandated in the same way that your BLS is, your manual handling, your fire. So if someone comes, it's because they want to. And obviously people may not be able to get released for training, or they may not identify it as something they need training in, whereas that's going to change. So where we are with that nationally, I know that there's been some local pilots. In the Midlands, it was done in Coventry and Gloucester, and before Christmas, the pilot feedback was kind of submitted, and Health Education England, which lead on this, are collating that feedback and kind of looking at the changes, and then that should be embedded nationally within the next year, hopefully. And that will mean that everybody, irrespective of their role, their band, what experience prior they've got with learning disability or autism, they will get the same training as everyone else in the country. So it means that and I think that the impact that will have will be invaluable.
Thanks, Ross. That's really good. I'm going to hand over to Sue and then Paula. But just to say about Sue, Ross, Sue is a newly appointed to the board, a medical member, but she has a particular interest in learning disabilities and the level of service that we provide. So she'll undoubtedly connect with you at some stage to think about how we can make that connection between you and the board much sharper. Okay, Sue.
Hi, thank you, Chair. I would say I've got an interest in this, and I work in another trust not too far away as a clinician, and I just want to make the observation that I think it's quite remarkable that you actually can sustain this level of high quality service single-handedly. Another place I work in has an entire team And I just salute you. And I'd also like to say, Amy, thank you very much for coming and talking to us. We cannot hear too much about this. Our very precious fellow citizens who just need a little bit of help, different sort of help. So thank you both of you.
Thanks, Sue. Paula, can you kind of sum up for us? And thanks.
Yes, and like I say, thank you to Ross and Amy. A very powerful story of how we do need to think about the challenges that arise with us within an acute trust and how we treat everybody fairly. For me, the pandemic's halted some of our training, which isn't helpful. But what we've got to do is think about how we do things differently. Paula McGowan, I have regular contact with. I did a learning disability conference at my last trust, which was brilliant.
She's been here as well. Yeah,
Paula joined us from Skype via Australia, but I also had the Misfits Theatre come in, and it was just amazing. So I do think there's an awful lot we can still do. And Ross, I appreciate, you're a one-man band, but you've got the work and the support of the trust, and I think the reasonable adjustments that we've made for patient P has gone over and above board, which I'm really, really, really chuffed about. It's really nice to see that. And on a personal note, I have a brother with a learning disability, so it is very close to my heart. So yeah, absolutely well done to both you and Amy for looking after P so well. That makes his transition into any kind of service within our trust very seamless. So thank you very much.
That's it. Yeah, that's the key. Yeah, thank you.
Yeah, and just finally to both of you, thanks very much for spending the time to do this. You'll be able to watch yourself back on YouTube later if you want to. I don't know whether P can watch YouTube, but anyway, you can see that. But thanks for bringing this to our attention. It's a really good practice. If I was a politician, Ross, I would say we're going to double the resource next year to your hand, but of course that actually is only one more person, and you've had them anyway in the past. So, but I won't say that. But it will be. I'm sure it will be better. I think the people of this part of the world, benefit significantly from the work that you do. Not only those people with a learning disability and special needs, but also generally. It's a general rule, I would say, that if we can get it right for people like P, we can get it right for most people. So thanks very much, and thanks very much from your sauna stroke, igloo stroke, whatever it is you're renaming. But I hope you're very happy there. But thank you very much for the time, and it's really impressive.
I just wanted to say a really quick personal thank you as well. I spoke to Paula really briefly about it yesterday, but I had a serious car accident at 16 years old and had to have my face completely rebuilt at Worcester Hospital. So I've had dozens of general anaesthetic there. I completely shattered the left side of my face fully. So I had a huge operation there, and Worcester became like my family, and they really supported me and my family. And the Hawthorne Suite was like my second home for many years. So I just want to say thank you. And I am also now pregnant, having my baby at Worcester as well. So you've been a massive part of my life. So I really wanted to say thank you.
That's three stories in one.
Yes.
But great. And when's the baby due? Sorry, not turn off.
June the 9th.
All right. Well, good luck on.
Justine, make sure you know her name.
Okay. Thanks very much.
Look forward to seeing you, Amy.
Yeah.
Thank you.
Bye then.
Thank you so much.
Thank you. Thank you.
Right then. Let's move on. Items of any other business? Are there any? No. Declarations of interest on the website, but there are no particular declarations about the agenda today. Minutes of the previous meeting, are they a reasonable reflection? They are. Thank you very much. They're approved then. Action log, Rebecca?
Thank you, Chair. The actions have all been updated as per the log. There are two which we've closed. Just in terms of the policies going through TME, that particular policy has been put back to March meeting. So there's a number of meetings that you can see that are coming through the March TME, and they'll come back through to April board.
Okay.
Thank you, Chair.
Thank you. Any comments, questions on that? No. Okay. Thank you very much. Chair's report. Well, I have nothing really to add. I would say that in the last few days there have been two very significant reports put out by the government. One on elective care. I think it's slightly misnamed COVID recovery. In fact, it's austerity recovery. But nevertheless, a big job for us to do in terms of getting our elective care back. I'm sure we'll have a report in the future about all of that. And then secondly is the integration white paper that came out. Again, a very significant paper, which is very wide ranging, covering everything from appointing someone for each place who has accountability for the whole of the delivery system in place, through to rules around power over foundation trusts, financial capital. So quite a wide ranging, but both of those, I think, at some stage in the future we'll need to have a further discussion about to understand what the implications of those are for us. Okay, let's then move on to the Chief Executive's report.
Thank you, Chair. And on those 2 points, we'll certainly work with Rebecca to identify the timings for those reports. Obviously, take my update as read, work in reverse order. I mean, I think the recent engagement with stakeholders, I think, is been helpful, and with Richard, we're continuing to build that programme of proactive engagement with our local stakeholders. The ICS development work, you can see there a number of appointments. Krishna Waring as the ICB chair, and further appointments have been underway in terms of the Chief Nursing Officer and Chief Medical Officer. One is fairly imminent in terms of the recruitment process. Draw attention to my note there about the Garden Suite Board. Colleagues will remember back in the early days of the COVID pandemic, there were a number of changes to our service disposition that were made in order to protect patients that were particularly vulnerable to infection, and one of them was to move the ambulatory chemotherapy unit from the Alex to the Kidderminster site. And we've been working with the clinical teams in the division to work through what the right approach to ambulatory chemotherapy across the county should be, and the conclusion being that particularly in relation to patient feedback, staff feedback, and travel times, that it seems perfectly reasonable to reinstitute the Garden Suite back to the Alex site. We're now working through the options for where that should be, because clearly we want to work on the basis that COVID infections and other hospital-acquired infections will be with us for the long term, and therefore we want to make sure that those patients are protected from any risks associated with that. And then just to expand on the note there about the clinical assessment unit, I think we've discussed at last month's board the background to this, and I'm sure there'll be some questions, and I'm sure Paul will want to provide a brief update. I mean, I think it's important, again, just to reiterate that there is a clear recognition that urgent emergency care flow and the pressures that leads to in relation to ambulance handover delays is something as a board we've continued to be really quite focused on and believe is unacceptable from a patient experience and a staff experience perspective. And there's also a well-known recognition that the emergency department at the Worcestershire Royal is too small, and hence that's being rebuilt, as well as the assessment areas being too small, and those are due to open later this year. We know also that there's been a lot of focus on trying to find space for ambulance crews to bring their patients in, to release them back to the community to see and treat patients that are waiting to be seen by paramedics and ambulance crew. And there's been a number of visits particularly to the Worcester site, to look at whether there is space identified for an offload of patients in a more timely fashion. Those visits have drawn a blank, but of course the problem has persisted. The Royal College of Emergency Medicine have identified the need for perhaps post-emergency department assessment space rather than before the ED staff review patients, and we had worked with the regional and national team to identify a space in the first floor of the oncology building, which capital monies have been made available to create what we're calling a clinical assessment unit. That is due to open in the first week of March. But in the meantime, Paul's been working with our cardiologists and wider teams to identify whether there is an interim solution, and with some movements in the way in which cardiology is being provided, particularly the coronary care units. Some space has been made available in Akenbury unit for a clinical assessment unit as an interim measure. And as my report states, it's relatively early days, but there's still more work to do in the way in which that unit facilitates ambulance handover delays. You can see that we're not quite yet where we need to be in terms of the length of stay in that facility in order to make sure that ambulances can be released by essentially reducing exit block in the emergency departments and therefore creating space. Active discussions are underway. Paul and Paula are discussing with Christine, with the clinical teams, about medical cover, about how we make sure that we can release general medical beds back into the system on the Worcester site, particularly constrained because our COVID inpatient numbers have continued to be high. We haven't seen yet a reduction in those. As of today, we have 2 more than yesterday, so 87 patients in our beds across the 2 sites, predominantly on the Worcester site. So there are a number of constraints to getting that working more effectively, but I know that the board will want to be and will continue to be very focused on making sure that our emergency patients are not waiting overly long on the back of an ambulance, and that we're able to create an environment pre the new ED opening where exit block can be reduced. Paul, I don't know whether you want to add a more up-to-date perspective in relation to the discussions you've been having, so the board's as up-to-date as possible.
Yeah, sure. So, I mean, I think what we've seen is that I'm confident that the clinical assessment unit concept will work, and I think, you know, Paula and myself in particular have been trying to push ways to make sure that we achieve the maximum 18-hour length of stay, and I emphasise 18-hour is the maximum, not an average or a minimum. And as you can see in Matthew's report, we're only achieving about a 35% roll through. The reason for that is when we set it up, we just as 2 days after it opened, we lost 17 more beds to COVID as we had to switch the rest of the Avon 2 over. What we found in the days that we've had the CAU operational is that the majority of patients, and by majority in excess of 90% of the patients who've stayed on that area, are GIM, general internal medicine patients, as opposed to cardiac, respiratory, renal, gastro, etc. And the last set of beds we lost to COVID were our GIM beds. So what Paul and myself are working on is to get Avon 2 back, in part 17 of the 22 beds back to green general internal medicine, and we're aiming to do that by next Tuesday. And there are 2 ways we're going to do it. One will be to go back to increase the number of COVID beds allocated on the acute respiratory unit, but the second way is that we're finding around, at any one time, anywhere between about 8 and 12 patients on Avon 2 who are surgical and are incidental as opposed to primary COVID. So we're going to create a COVID area on the surgical wards and manage those patients there, because they'll get better care if they're managed by the surgical team, both nursing and medical, on the surgical wards, rather than being managed in in a COVID medical, and virtually all of these patients are presenting for emergency surgery and just so happen to have COVID. They are not primary COVID. So that's what we're going to do over the next few days. We can't do it immediately because it takes time for us to move patients and beds around, and also given that Avon 2 is a COVID ward, there's a major clean that we would have to do before we can then bring it back into general use. So that's the plan, and as Matthew has said, we remain on plan for the first floor of the radiotherapy unit, which will provide a larger CAU to go operational on the 1st of March, and certainly discussions involving the team and Kia, that development is moving at a pace and will achieve the agreed handover date. So that's very positive.
Thanks. Julie.
Thank you. I mean, recognise this is a plan that's evolving and it's moving very quickly, and everything Paul's just said about freeing up beds is great. But I think there is still concern. You call it a clinical assessment unit. I think as well at Quality Committee, we're not quite sure who's doing the assessing and when. I was going to raise this as part of the Quality Committee report back, but I might as well do it here since we're discussing it. I think the actual clinical model for people who've come in acutely still needs a lot of clarity about who's doing that, who's medically responsible, and escalation procedures. We raised this before, but I'm still not quite clear about how that's going to operate. So it will be coming up. It's going to be a standing item agenda on the Quality Committee agenda, but I really would like to have some more clarity and assurance about how patients are being looked after medically.
Right. So
Sorry, Paul. Hold on. I've got Sue Sinclair as well. I just want Sue to ask her question. I noticed that Christine has put her hand up as well. So, Sue.
Thank you, Chair. Yeah, Paul. Obviously, times are very, very difficult, and you clearly evolving plans to try and give us a bit more comfort over the next few weeks and months. Can I just ask what you have in place for the patients who are currently staying there for 3 days, and therapies input and things like that, because we cannot get away from the fact that these patients are staying there at the moment, and you cannot, for all the constraints that you're having to try and work out, you cannot solve this in the next few days or weeks.
Christine, do you want to respond, and then I'll bring Paul in afterwards. Christine.
Yeah, thank you. Can just to be clear about the clinical model that we were trying to implement, and why we have struggled with it. So the situation at the moment with patient flow for medical admissions is that we have a lot of patients in our emergency department who have a decision to admit under the medics, 20 or 30 at a time. That means that our acute physicians, who should be based on the medical assessment unit in Worcester, are essentially providing a medical assessment unit within the ED. So they are doing the rolling ward rounds within the ED. So they've seen the patients, they've had a post-take ward round, they've been assessed, they've got a treatment plan, we've allocated junior doctors to look after them, and they're being continuously reviewed by the acute physicians. That is what should happen on the MAU. The MAU, however, has turned into a normal ward. So normally with an MAU, you have a bedded capacity for short stay patients that are staying for up to 72 hours. And then you have assessment areas where your GP referred patients and so on can be seen, and that's where your acute physicians live. But because we're full, that ward has turned into a ward. The idea of the CAU was effectively to try and empty that area. So the idea was that patients who were in that area who needed to move to a downstream ward under one of the specialty medicine teams, or who were general medical patients who would have an expected length of stay for longer than 72 hours, would move to CAU whilst waiting for a bed on the downstream ward. And that would empty MAU and allow that space to function differently. The problem that we have had is that we haven't had the downstream beds to move the patients to off CAU, because we've effectively carved out some of our general medical capacity and turned it into a CAU, and we haven't created any additional capacity. There's not a single extra bed or a single extra space to look after patients anywhere in the hospital. We've carved out of what we've got, and that is why it isn't working as we had hoped. We've learned a lot from this, including learning, I think, some old lessons, which is if you create something that looks like a ward and you put lots of beds in it, then it turns into a ward and people stay there a long time. And this is an old lesson. We've learned it in the past. If we've put beds in endoscopy for temporary, if we've put beds in the discharge lounge, if we put beds in theatre recovery, which Sue will know all about, it turns into a ward and patients don't move. So I think what we need to do is we need to take the learning from CAU and apply it to when we've opened the white space, and perhaps think about doing things a bit differently. But the difference between trying to operate the model and the white space is it will be extra space with extra capacity for the patients, and that will be the thing that makes the difference. I think we would all acknowledge that what we have done is we've done the first of a PDSA cycle, and we've learned a lot from it, and we will take that learning forward.
Thanks, Christine. Richard.
Thanks, David. So I wanted to maybe challenge the entire CAU a little bit more, because I'm just wondering if we are not just shifting the problem here. I'm not entirely sure whether we are creating new bed capacity or not, but we're definitely putting a strain on staff, the same medical staff, the same nursing staff that we've got. And as long as we don't solve our discharging problem, it's only going to take a little bit of time, and we are in the same situation. So that's one. And are we not wasting our energy is fundamentally my question. The second one is on the garden suite. I just wanted to understand, is this decision, I understand distance, travel times, is this more staff driven or patient driven? Because I'm not ignoring it's important for staff, obviously, but in the end we are there for patients, and we shouldn't do this just for staff. So that's the two questions.
Okay, thanks. Paul, do you want to add anything to what Christine said around the CAU before I ask Matthew to talk about the garden suite?
No, I mean, I think Christine said exactly what I was going to say. The only other thing I would add, one thing that Julie raised, the medical input into that ward is being managed directly by Jasper Trevelyan as the divisional director, and he's provided a medical rota of consultants, and that rota is always rolling 2 weeks in advance now.
And therapists?
No, there aren't therapists on that area, and I'll happily explain later, perhaps in the private meeting, the reason for that.
Okay. Julie?
Can I just say, it'd be very helpful if we could have the sort of detailed staffing plan of this unit at the next quality committee, because what's being said now is about the medical rota, but it's first presented to us as a no doctor area, keeping doctors away from it, and actually that gave us cause for concern, and now it's changed. So I think it would be really helpful to have the detailed staffing model come to next quality committee of not just doctors. I'd like to also to see the therapists and everybody else and the whole support system. Thank you.
Okay, thanks. And then the garden suite, Matthew. Is it driven by the staff?
Yeah, thanks. I mean, it's an important question, Richard, and I think the thing that we always said when the move was made, that it was temporary, and that when we needed to consider the longer term future, it would be driven by patient survey. And we have conducted a patient survey, and actually I met a number of patients on the 2 visits before Christmas that I made to the garden suite who were really complimentary about the care they were receiving. But particularly, well into the cycles of chemotherapy, tiredness really kicks in, and travel time really makes a difference. So first and foremost has been a patient-led decision. We all obviously also surveyed the staff as well, and I think there was a reasonably mixed reception. Some of the staff that have been recruited from the Kidderminster site over the last couple of years were reflecting their preference. Obviously, the longest-standing staff who'd been there pre the move had a particular view. So that was a fairly balanced picture, I think, Richard. But the dominant view was from our patients that the travel time was prohibitive. I think the other piece which I've alluded to in my chief executive's report is that the service does need to look at the demand and capacity across the 3 units to just make sure that they're balanced in the right way, because demand is increasing, and we know, don't we, that a number of patients are still to be diagnosed, still to be tested, likely to join the service. The unmet need that's out there as a consequence of the tailing back in the first year of the pandemic of services. So the team really do want to look at making sure that the capacity in each of the 3 facilities is as good as possible. But short answer, yes, patient-driven more than anything.
Okay, thanks for that. Can I just go back to the CAU though at the end of it, because I think we're all concerned about this, and I think Julie makes the point, and we would look to the quality committee to have a proper look at this, not least of all the safety of it, the medical and nursing and therapy staffing, the admission and discharge procedures around it all, to see that they're working properly, and the impact that it's supposed to have on ambulance handovers. And I think, taking Richard's point, is that we need just to put a stop, we need to put a step in this to make sure we don't just transfer something that doesn't work from one building to another. And I know everyone's keen to get the building up and running, but to be frank, if all it's going to do is create a whole load of problems in flow and add another step to something, we should avoid doing it. So can I ask the chief executive and the executive just to put a step in your process around this, to make sure that when we get to a point where we can open it, it is actually going to deliver the benefits that we require. Okay, thank you, and thanks for the work that people are on the garden suite, and I recognise completely that this is, in a sense, the beginning of a decision, in the sense of we've made a decision where it's going to be, but actually finding out where to put it and getting the capital and building it and all of the things that go along with that is going to take a bit of time. So this is not an overnight solution to that particular problem. Okay, thanks for all of that. Let's move on then to COVID safety in the workplace. Tina.
Thank you. During December and January, we will...
I'm sorry, Tina, I can't hear you. Can anybody else? Can other people hear you? We can't hear you.
Can you hear me now?
That's very faint.
Let me just take out my... How about that?
That's better. That's much better.
Okay, so during December and January, we were working to implement the vaccinations as a condition of deployment legislation that was due to come in place on the 1st of April. That required staff involved in the provision of CQC regulated activities and providing frontline direct patient care to be vaccinated for COVID. That legislation has been put on hold by the government on the 31st of January, and it's subject to consultation, which closes on the 16th of February. So we won't know the outcome of that consultation until later this month. However, we're still of the view that the COVID vaccination for staff is the right thing to do for the safety of our patients, staff and their families. So what we're taking forward is conversations through 2 routes to make sure that we've got a safe environment and also understand the individual needs of our staff through the occupational health risk assessment process. So we are refreshing our environmental risk assessment.
and also the occupational health risk assessment policies and templates to make sure that we've learnt the lessons from the last 2 months regards to the VCOD conversations and processes. That the meetings have taken place with clinicians in the organisation to refresh those documents, and we've completed the occupational health version, which is going through our command structure today for approval. In the report, you can see the current compliance for the risk assessment. We're at 92%, and it's really important that we achieve 100%, that every member of staff has had that conversation with their line manager, and where necessary, that includes their vaccination status and then any reasonable adjustments we need to make according to their individual health needs, etc. And so to improve that compliance, we've agreed some actions you'll see in the report through the command structure, and we're reviewing progress against those actions each week. There's further work to be done around the environmental risk assessments, and the oversight of that will be through our health and safety committee. We're happy to take any questions.
Thanks, Tina. Any questions, comments? Anita?
Thank you, Tina. And obviously this has been a really difficult time for us and indeed the NHS nationally. Apart from, we're really clear that we still support and advocate for vaccination, and that's absolutely fine and right. I am starting to hear anecdotally comments about in areas of the trust where there are perhaps some individuals who have not been vaccinated and have chosen not to be vaccinated, issues around cultural issues developing in those areas. And I'm thinking specifically about either staff that are vaccinated feeling concerned because there are staff on there who are not vaccinated, but similarly I've heard issues where unvaccinated staff are, in the words of one individual, being made to feel like lepers and are actually feeling victimised by staff that are vaccinated. Now, clearly this is a really difficult situation. I wondered whether it was this is just anecdotes that I'm hearing. Is this something you're aware of, and is there anything that's in place to try and help smooth some of this down?
Thanks, Anita. Can Colin's got a question as well, and we'll take them both together if that's all right, Tina. Colin.
Yeah, thanks, Chair. It's a very simple question, really, about the proposed timescale. In your report, Tina, you say there's about 500 occupational risk assessments for individuals outstanding. So, how soon do you think we'll get to 100% compliance?
So I'll answer Colin's question first, which by the end of March is what we're aiming for, Colin, on that. And you'll see in the action plan that we're asking each of the divisions to do a corrective action plan by the end of this month, so we can implement it during March. That's the period of time. In response to Anita's question, we've had some feedback on that, but we don't disclose the vaccination status to the wider staff groups. Only the managers that are aware of their staff's vaccination status, and that's in line with GDPR requirements. We have had patients ask about the vaccination status of staff members as well, and that's why we're taking the view to refresh our environmental risk assessment policy and template, because that will make allowances for if we have got staff that are unvaccinated working in those areas, what the risk might be to colleagues and to patients, and therefore we've assessed that risk and put mitigating actions in place where appropriate.
Thanks. I was reading, Tina, about people who had resigned coming up to this date and are now wanting to come back to work for the NHS. Have we got people in that category?
Yes, we had 3 people that submitted their resignation, so we've contacted those individuals and supported them to retract their resignation to remain employed by the Trust.
You're very generous. I mean, because presumably we've got a policy that new recruits, we don't take new recruits who haven't been vaccinated.
So because of the legislation still in place currently, which allows us to say that's a requirement of employment going forward. But if the legislation's withdrawn, then there will be no basis for us to insist that it's been a mandatory requirement, unless we make that a condition ourselves as a trust. So it's the reason for the resignation was because of the mandatory vaccination. Obviously, we will still continue to have conversations with those individuals about the importance of having the vaccine. And we also, in regards to new recruits, it's about making sure that we're clear on the trust position around vaccination. And we're also, part of the selection process, asking candidates questions about their vaccination status and views around that as well, so that we're actually recruiting people with the same values as we have as an organisation around this.
Richard.
Yes, Tina, I just wanted to understand a little bit better this 8%, the 500 people. Is that largely because they don't want to do this occupational health assessment, or does it have practical backgrounds like people on leave, people on sick leave, and all those types of things? So you just understand the nature of the problem a bit better.
Yeah, so the figures actually exclude those on maternity leave and long-term sick. So that this we've taken those cohorts out already. So this is people at work. It's a mixture of things, Richard, is that this is a live database, so it includes all new starters. So we've refreshed our onboarding processes to make sure that the risk assessment is part of the local induction, rather. That was one of the issues that we faced, was being delayed because people weren't picking that up. So we've corrected that. But it is HODA managers to account to do what we need them to do on this, to make sure that those conversations and forms have been completed. That's something that we now run reports through with the lists to those managers, and have they oversight at the bronze meeting every Monday.
Okay, I think there's a bit of work to be done around this. I'm sure Tina's completely on all of this, but can I just kind of do a couple of things to sum up? One, to reiterate the position of the board is that we think the best way of protecting our patients and protecting our colleagues is for our staff to be vaccinated, and we should continue to make that argument at every opportunity that we can. Secondly, can I thank Tina and her team and all of the various people in the organisation, the matrons, everybody else who've done an enormous amount of work to get as many people vaccinated as we have. It's been an enormous effort to make that happen, and they've done a fantastic job for the organisation and a fantastic job for our patients. There are some issues around how we deal with this going forward, I think, not least of all what our expectations are about new starters and the rest of it. But no doubt we'll come back at a further stage and deal with that accordingly. So thank you for that, and we recognise what's happened, and let me just get this right. We take assurance from what you've done. Okay, thank you very much. Let's then move on to the integrated performance report. Vicky.
Thanks very much, Chair. Hi, everybody. This is the integrated performance report for month 9, which is December. It's got an overall assurance level of 4, which is an unchanged assurance level. It was approved at our Trust Management Executive meeting in January and assured through the various subcommittees of the board. The board is asked to receive this report for assurance. As a team, we've identified some key messages which are highlighted in the executive summary, and those relate to the triple challenge relating to emergency and urgent care, patient command capacity, which we've touched on earlier in the meeting, the recovery and restoration of the elective programme, and also the rising cases of Omicron, which we were witnessing during that December period. We've also identified infection prevention and control as a key highlight, particularly the number of C. diff cases that we reported in December, which exceeded our national target at that point in time, and staff absence relating to COVID and non-COVID absences, as well as that increase in staff turnover, which relates to the non-registered workforce due to the competition within the employee marketplace. Also picked up the financial position in terms of an overview of the month 9 position and what our forecast outturn is for this financial year, and the capital programme position at month 9. And I'll pause there. Thank you, Chair.
Okay, thanks very much. I'll take each of the headings, so if people want ask questions about each one, we'll go through. Urgent and emergency care patient flow. Any questions about that? Simon.
Thanks very much, David. I know we've touched on this already, but is there an update on how we're doing with our discharge pathways with partners? I know they're struggling as well, but it would be useful, I think, to have that on the public record of where we think we are with that.
Thanks. Paul?
I think it's fair to say that that the number of patients that we currently have as inpatients who are waiting to be discharged via one of the pathways, either home on reablement or community beds or nursing home, remains a challenge. I think colleagues across the system are working well together to try and improve the situation, but we remain having to live with a significant number of patients in our beds who no longer require that care, the acute care. And more recently, we've found an increasing problem in relation to access to the stroke rehab beds at Evesham, which has emerged as a bigger challenge over the last couple of weeks. So, to be honest, Simon, there's still a fair amount of work that we've got to do on that.
Is it getting better or worse, Paul?
I can't say it's getting better.
Right, Anita.
Thanks, Chair. Thanks for that, Paul. I wondered, could you specifically talk about discharges before midday and criteria-led discharge in terms of things that we can do ourselves, and are we making progress in that? Thanks.
So in relation to discharges before midday, performance remains variable on that. We have improved the position, getting up to the low 20s from being around 17-18%. But as you know, the aim is to try and get that up to around about 33%. So we've had over the last 2 months about an average of about 4 to 5% improvement, but still significantly below where we aim to be. On criteria-led discharge, then Christine and Paula have really been pushing that, making the whole process more simple. And we have seen through the discharge cells examples now of patients going via the criteria-led discharge, and what we've agreed to do is to do an audit at the end of at the end of this month on patients discharged to check how many have been discharged by the criteria-led approach, the timing of those, and to understand whether there were opportunities for a higher level of criteria-led discharge that we didn't take, and that was the case. But I think the work that Paul and Christine have done in smoothing out and making it far easier to achieve rather than complex forms to fill in have made a positive difference.
Can I just ask a follow-up? And do you see those two things as being connected? In other words, if we could get criteria-led discharge right, that would in turn give us the is that the primary reason we're not getting the midday discharges?
I wouldn't say it's the primary reason, Anita, but it's a contributory factor. You know, if you don't have to wait for a medic to come back to say X, Y, and Z on the bloods or whatever, if you've got written in the notes, if A, B, and C happens, that's fine, discharge. It does bring discharges earlier in the day, but it isn't the primary cause. I think one of the things that we talked about, again, between Paula and Christine and myself with Matthew, is we do need to perhaps sharpen up a bit around job planning to make sure that that important and experienced and expert resource is actually geared onto wards early in the day, and that's more prevalent in the surgical specialties than the medical at the moment, and I think that would make a positive contribution.
Richard.
Thanks, David. So I need to ask, let's say, half of my question, because when I look at the figures overall related to urgent care, performance is back to like almost when we started with Home First in 2019. So, and we know there are external factors. We obviously have a lot of understanding for the effect that COVID has on the entire performance of the hospital and the stress on our staff. But the question I've got is, what are we doing to really make sustainable change here? Paul explained in the last Finance and Performance Committee that a number of these actions are then executed by making sure that senior executives directly get involved in the process, which is, for now, it's showing some leadership and trying to push the dial, but that is not sustainable, of course. And so, how are we going to attack this problem more fundamental? I want to go back to two things that we've discussed earlier. One is having the discussion with system partners that part of the risk should sit with other partners and agreeing some thresholds there, so we don't always get into the situation that we're currently in as a hospital. And the second one is those things that we can influence ourselves, really execute them a lot better. And that was Anita's question.
Okay, Matthew.
Yeah, I mean, my hand was up originally to respond to Simon's point, but I'll answer a bit of Richard's point as well. I think, Simon, the question of delayed transfers of care and delayed discharges is a region-wide point. There was the target that was set at the beginning of December to reduce patients that had no reason to reside by 25-30%. It's actually gone up. Ours has gone up. Pretty much most of the places overall in the Midlands region, it's gone up, not down. So I think the collapse in the social care market is one of the key contributing factors, and that's not just in this county. It's certainly elsewhere. But Richard, I agree. I think what we've identified through the discharge cell is really some very, very slow processes that hamper rapid discharge from hospital through to social care packages of care and to community hospitals, and that remains the area that I think needs a fundamental rethink about how that's done. We see a quantum of discharges into pathways of care which are not hitting the targets that were agreed and has not on any days, and I think that is partly about capacity, as Paul said, partly about process. And whilst the discharge cell led by Paul and Paula is not a sustainable way of working, and it's quite contrary to the way in which we want to organise and run the hospitals in delegating and making sure people are doing their jobs properly, there is a real need to set clear roles and expectations, not just for our staff, but also for those that we work with across the system. I still think there's more to do in relation to people really taking their fair share of the risk, and clearly that's an ongoing conversation with my senior colleagues across the county. But because of capacity constraints, I think that's one of the things that is holding us back. Certainly process improvement opportunities, but capacity constraints is a real issue in terms of vacancies in social care and in community services. So I think we'll press on. We've got to continue to address this point about process improvement, but we've got to do what we can locally in Worcestershire to try and improve the vacancy and fill rate in these roles. That's a major issue for us.
Simon Adams.
Thank you, Chair. Point of information for me. Can the Chief Executive tell me if there's a forum in which the risk that each individual organisation across the system holds is actually reviewed, or where we could make a contribution? Because it does occur to us that your trust carries an awful lot of the risk that directly impacts on patient care and safety. And we'd like to be reassured that across the system, the other trust and other organisations are sort of reflecting that in their own appetites for risk.
Yeah, thanks, Simon. So the Home First Worcestershire Committee, which is a system-wide committee subset of the Worcestershire Executive Committee, is the place where that discussion is. Clearly, the place-based system meeting as the Worcestershire Executive Committee you're a member of, and that is the overarching place where this needs to be really addressed. I think one of the things that we've been looking to do is to try and get more visibility on some of the determinants to good flow through the whole system in terms of length of stay in community beds, length of stay in packages of care, so that we can really understand how that fares compared to best practice, because we have an awful lot of data that we look at every day. We want to see that visibility across the system of the key indicators, and in Vicky Lewis's team, Nikki O'Brien leads the information cell for the county in trying to extract real-time quantitative information that really enables us to have visibility in that. And I don't think we're there yet, Simon, but that I think will help to get clear visibility on where the risk sits.
And I think we need to press the issue then in the Home First committee and look for assurance. And just for information, we're also in a discussion with the Adult Safeguarding Board, because they have an interest in risk management across the discharge system. Thank you. Thank you, Chair.
Thanks, Simon. I mean, a really important point that I think that both Simon and Richard have raised, to make sure that we have a proper risk share across the various organisations with triggers which trigger both financial and managerial responsibilities and action. I think that would be a really good thing for us to have. So we look to the Home First Board to put something rapidly together. As we all know, our weakness has always been our own processes, really, and unless we can get them right. And the frustrating thing, I guess, from all the board's perspective, is that whatever we seem to do seems to make no difference. Richard pointed out that we were, back at some place, and that 2019. Don't forget, during that period, we've had endless initiatives, objectives, more beds, CAUs, you name it, and we've thrown it, and none of them seem to have delivered the change that we need. So I really do think from the executive we need a really thoroughgoing view about what it is we're actually going to do that's going to make the difference, particularly around the ambulance handovers, the whatever they call the nurse-led, or whatever they come up with, nurse-led discharge, numbers of patients waiting be discharged before midday. Those things need really to start moving. Otherwise, what's the point of continuing to chip away at all of this? So, can we ask Matthew and the team for the next meeting to set out what we're actually going to do, and if we're continuing to do things that simply don't deliver, then why are we continuing to do them, really? So, okay, let's move on then to quality and safety. Any questions on this? Anita?
Sorry, my question was actually another one on the next bit, which was on recovery and restoration, just before quality and safety.
Oh, sorry, I've moved over one. Sorry, go on.
Just a quick question. It's about patient-initiated follow-up. There's a comment in there that says we're not going to be able to do it. Could somebody explain why that is? what are the barriers to us achieving the targets on patient-initiated follow-up? Thanks.
Sorry, Anita, that's a mistake, because we are going to do it, and we're aiming to achieve a higher proportion than is set out in the NHS plan. So the plan, we're expecting to exceed the NHS plan by 10%.
Thanks. Paul, I know this is completely unfair, but I'll do it anyway. You know, you've seen the elective recovery plan. Is there anything in that worries you?
This is a public board meeting, Chair.
Yeah, but do we think from our perspective that it's relatively sensible and most of the things in it are deliverable?
I mean, I think the biggest challenge is going to be over is diminishing the long waits, isn't it? In the plan, and simultaneously reducing the overall size of the waiting list. Now, the original plan was that those patients waiting over 104 weeks would be eliminated or treated before the end of March 2022, and in the plan that's been pushed back to July. For us, we are still seeking to achieve, board members will recall, excluding orthodontics because of the particular issue there. We're still pushing to achieve seeing all those patients waiting over 104 weeks by the end of March. The position at the moment, the number less orthodontics was running a couple of weeks ago at 963 over 104 weeks, and that position today is 480. So we've treated or seen nearly 500 patients in since the 19th of January, and we continue to focus on that. And I think in terms of the targets set out in the plan, that we don't have anyone over 104 weeks by the end of July. I have to put in, as I constantly do, the exclusion of orthodontics because of its history. I think that is going to be challenging, but will be achievable for us. The bigger challenge will be around the 78-week waits, and we're working through that at the moment. But going back to Anita's point, the whole issue for us around PIFU is if we can accelerate and exceed the NHS target for patient-initiated follow-ups, that will free up capacity to allow us to see more new patients. So I would say yes for 22-23. It's too early for me to respond to 23-24.
I'll take that, Paul. I'll take that. Okay. Quality and safety. No. People and culture. Quite a good discussion about that. Financial position. Any questions on the financial position? Simon.
Actually, I'll defer to Richard first, seeing as he chairs the committee, and I'll come in with my question because I'm sure his is more intelligent than mine.
No, Simon, you're too modest.
Well, we'll make a judgment about that afterwards, Simon. We'll help them both.
Let's do a little contest then. No, yeah, in essence, I just wanted to probably express my concern and then understand what will be done about it, which is when we read all of the report, and part of this discussion did take place in finance and performance, but the majority of finance and performance has been focused on operational performance, so we didn't have a lot of time to spend on this. But clearly you can see that in the forecast we're predicting a higher deficit than what we targeted ourselves with. There are two dominant reasons given. One is more income related, you could argue that, and the other one is really related to cost, and the largest part of the cost increase comes from staffing costs. Yeah, whether that's our own staff or bank and agency, that's what's really driving it. And the reason that every little issue that we get unexpected has an effect on the forecast is that we don't have any opportunity to offset it with other things. So I've got two questions. One is, what are we doing to create opportunities for us to save in other places so that we can actually manage our forecast more actively than we are doing today? And the second thing is, when you look at staffing, and I've got the number here, Tina put in her report, we've got 355 whole-time equivalents more than last year. So it's not, we can all just do the calculation. We've increased our run rate significantly. And partially that's related to COVID, and partially it's related to all kinds of other things. So what are we doing to reduce that run rate so that we still exit the year with an exit rate that helps us next year? Those two fundamental questions.
Dave, sorry.
Simon, do you want to ask yours, and then we can deal with them all together?
Yeah, thanks. I was going to raise the staffing issue because we've discussed this before in terms of the added pressures of bank and agency and where that's now leaving our financial target. The other question I was going to ask is, how do we now compare with other partners in the system? Clearly, we're not forecasting hitting the deficit we'd originally set ourselves, or the figures we'd originally set ourselves. How are other partners doing, and how is the system coping with that?
Okay, thanks, Simon. So, with Robert.
Thank you, David. And can I first of all just make a point and apologise? What we said as well in the forecast figure of 4.3 has been shared and agreed with the system and NHSI. It's actually been made aware, noted, rather than agreed, because I am still in discussions with Mark Dutton from the ICS perspective as to how we can make sure that comes back to the number that we committed to at the end of the year. Okay. Because clearly one of the items is a planning deficit, the 1.8 million in terms of independent sector, and the other one is any costs of the clinical assessment unit. So I think that's just a point I should have said noted rather than agreed. In answer to the last point about how this impacts on the system, Simon, I know it's a public board, but we're in a peculiar position across the region of many areas have been arguably overfunded and are not spending where they were at the minute. So that's probably why we're sort of saying the NHS regional aren't concerned about a couple of million in that sense. That's not the same as we should be concerned, as Richard's point about the whole impact on our run rate, and particularly moving into next year, which I know we will cover later. So that's the partner section. They're really no different in their position as far as I'm aware. But I haven't got the full picture, and perhaps that's something myself, Colin, pick up at the ICS forum tomorrow just to check what this is, because I haven't got the system view for the end of this year. In terms of as Richard says, the underlying run rate, we're not a trust that's had the opportunity to put away contingency purely because we know we've got a gap even in the old days of PVR versus how we are with block in terms of having contingency. What we are doing and have continued to do, certainly with the finance team, is and everybody's in all the corporate areas are working just as hard as anybody else, is continue to be looking at all of the spend areas. And my operational business team work with all areas to look at where there are opportunities in terms of areas that haven't spent and where we can adjust and what else we can bring in. But we don't have a contingency developed, and the ability to really mitigate is I think what we need to be talking about as part of a strategic objectives going forward is actually the urgency and the need for us to find a way of being really more efficient and deliver the services better. That's as simple as I can put it.
That's exactly my point.
Where in the plan for this year did it say we're going to increase the staff by 350? Where in the plan was that? Hello?
I can't answer that one at the minute. I need to.
But you know, I mean, either the plan is wrong, or we've no control. You know, what is it that's created this massive run rate issue that we seem to have here? Tina.
So the increase in establishment would be from business cases, approved business cases, and new service areas. So would be part of the budget setting round for last year.
So there was source and application funding against each of these 350 staff, were there?
That was that information we provided through the workforce plan earlier in the year, yes.
Therefore, there shouldn't be a financial pressure because of it, should there? If they've all been funded and they're all in the business plan, then why have we got a financial problem, and why have we increased our run rate to go into next year? Sorry, that's a rhetorical question. Simon.
I'm probably wrong on this, but I'm assuming part of this is to bring our reliance on bank and particularly agency down by increasing the headcount that we have ourselves. I might be wrong on that, but I was under the assumption that was part of the justification for some of this.
That's true, but then we need to see that also reflected in the figures.
Yes,
and I think the issue about the contingency is not that you can invent contingency, Robert. No one can invent contingency. No. You create it by looking at opportunities to become more efficient. And I think that's part of the issue. Of course, partially related to the focus on the crisis. I get it. But everything that is not going according to plan has an immediate effect on our forecast, because we haven't created these types of things.
Yeah. Okay. Let's move on. I think the issue here is that the forecast of 4.3 million is clearly not in line with what we agreed as a board, and that we expect, even in the time that we've got placed, for the executive to take action to bring it back to the place where we agreed to begin with, and whether that's through negotiations with the whatever they call themselves now. They're still a CCG, aren't they? With the CCG or whatever, we need to make sure that we deliver what we said we would deliver. That's the first thing. And the second thing, we just need to take on this increased run rate issue into the conversations we're going to have later about the 3-year plan. Matthew.
Yeah, sorry, Chair. I know you're trying to summarise there, but I think just the key point is that we will be bringing, discussion started this morning on how we bring that forecast back to where we have that target, and clearly the discussions about the non-recurrent and recurrent nature of the support from the CCG into this year's position is part of an ongoing discussion. So we would be expected to bring that back in line. In the way that Robert's articulated, with the 1.8 that is the income-related issue, and the assumption about costs for the CAU being met by the CCG. So we expect those points to be noted.
Fine, thanks. Let's move on then to the committees. Finance and performance, Richard. Anything you want to? Let me just get this. Which page are? Oh, they're on page 95. Sorry.
I think we've discussed the most important points, David. The others are there for noting, and we'll follow up in the Finance and Performance Committee.
Yeah. Can I just say, as an aside, I think the reporting mechanism is a big improvement, in the sense it's simple, straightforward, and you can work out where the assurance is and where it isn't. So, thanks for Rebecca and the team, and Colin, everybody working on this for us. So, any questions on the finance and performance? We think we've given it a good airing. No, let's move on then to quality governance.
We've talked already about the admissions unit, but we were also spent some time on infection control. I think one of the things that took us by surprise was the loss of the bed cleaning facility, which we're now assured is coming back, particularly around the C. diff incidents around that. But I don't know if that's back already yet, Paula, is it?
So I did ask for an email to be circulated to you all, and I'll make sure that that's been done. We have got a Ward 15 to be used at the Alex site, and for the Worcester site, we've got an area by the restaurant that we're going to have to partition off, and obviously that's going to be a revenue consequence, but then you park that with actually reduction in C. diff and length of stay, bed days, that might just equal out. But Paul and I are working through that with regards to what that cost would be.
So infection control and clinical assessment unit are the main items. The rest is as read, really. We'll continue to keep our eye on those things.
Thanks very much. Let's move on then. People and culture.
We've covered most of this because we did spend a lot of time around the vaccination programme, and you already echoed the thanks for the amount of work that had gone in that was then not necessary in terms of the change in policy nationally. So the rest of the report, I think, is as read.
Thanks very much. Any comments? No? Okay, let's move on then to safest staffing report. Paula?
Thank you, Chair. So I'll take the report as read. Overall assurance level of 5. What we have seen is that from December 2020 we had an RN vacancy of 269. That has reduced to 99 by December 21, which is a positive. We've still got quite an issue with the healthcare assistant turnover. So we've gone to Indeed, and with Indeed and working with our own adverts to go out to recruit to healthcare assistants, we've got 90 applicants in the pipeline this week to be interviewed, and obviously we're concerned about that particular element of that turnover and the gaps in the ward areas. I will just stop there because I think the report says it all, and I'll take questions, Chair, if that's okay.
Yeah, that's fine. Thank you. Any questions? Okay, thank you very much. And that's assurance level 5, is it?
5.
Okay, thank you. Any questions? Let's move on then to midwifery.
Yeah, thank you. Good morning. So our midwifery safe staffing report, I just wanted to identify that we and point out that we'd reduced our assurance level to 4, and that's because of our increased COVID absence and sickness absence as well. We did see a rolling increase in our turnover rate, and I've highlighted in this report as well some red flags that we can now report a bit more accurately because we've got our acuity tools in. Activity was very kind, and that did help us manage acuity a little bit better. However, some good news is that we've recruited 11 whole-time equivalent midwives during December. We've got 2 further recruitment events, one that we've already held in January where we've offered 3 posts, and we've shortlisted another 9 midwives who will be interviewed during February, so that's really good news. Although we've implemented all of the acuity tools, you'll see within the report that there is a word of caution in terms of the completion rates, and we're doing some more training with staff to make sure that they're more accurate going forward. I'm anticipating a slightly improved position in January, and we're supporting the staff with additional weekly huddles throughout the period of December and into January, and they've extended into February now as well. So I'll stop there and answer any questions, but the rest is in the report.
Thanks, Justin. Any questions in relation to that? So is your expectation that the assurance level is going to go back down to 5 when we do it next, or are you too soon to say?
Yeah, I'm just pulling the January report together at the moment. I've obviously got some outstanding information, but I anticipate it will look better during that period.
Thanks. Very political response. Thank you for that. Simon.
I'd imagine a similar answer to the question I'm about to ask now, but I think first it's important just to pay tribute to how hard staff are working on maternity at the moment. I note the euphemism of incredibly flexible workforce, which I presume means a lot of people working very hard and doing stuff that normally they wouldn't do because they have to, and they're putting those extra hours. And so I think it's fair that we say thank you for that, and I know it's ongoing. I just wondered if you could say a little bit more about the red flags. I think some of them haven't been reported before. I don't know how much more information you can give us about that, but it'd be helpful just to get a sense of what they are and if there are any trends developing there.
So within the report, you'll see now that we now are able to report all the red flags within the Acuity tool. So the accuracy of those is much better, because we previously relied on our Datex system to tell us about our red flags. The ones that are particularly of concern that I've highlighted within the report are providing women with one-to-one care in labour. We've never seen that reported before. And also the supernumerary status of the shift leader within the delivery suite, because obviously if their attention is taken away from the helicopter view of managing that acute area and they're providing clinical care, there is a potential risk there that's well recognised. So we've done a lot of actions to support those teams to try and reduce the red flags. Our training has been cancelled. Our ward managers have been out into the clinical area, working clinically rostered, and that has improved things. And going forward into January, you'll see that those red flags have reduced somewhat. And the other biggest one that we've talked about before is the induction of labour pathway and the delay in that. And we've seen a considerable improvement in that through January and into February.
Excellent. Very good. Very good. Matthew.
Yeah, thanks, Chair. Justin, I wonder if you might just want to let the board know about the recent good news on what used to be CNST.
Yeah, so we received notification yesterday that we will receive our full rebate because we were able to provide assurance against the 10 safety elements. So we're incredibly pleased about that, and that's our second year of achieving that. So that's a really, really great news for the team and a lot of hard work. Just a word of caution though going forward is that the requirements for year 4 CNST have really raised the bar, and it will be very, very challenging to meet that. I know we've delivered 2 years running, but I wanted to be quite realistic in possibly what our outcome might be next year.
We have confidence in you, Justin.
We will do our very, very best. We will do our very best, and we're investing in a post that for a midwife to particularly focus on that. So we are doing everything we can to make sure that we do achieve those safety elements.
Thanks for that. Any other questions? Okay, well, thanks for that, Justin. We note that for assurance. Thank you.
Thank you.
Let's then move on to the Audit and Assurance Committee.
Thank you, Chair. I'll take the report as read. Just a couple of things I just wanted to highlight. We did have the first of the new format reports on tracking status against the value for money audit recommendations. I think we liked the format of the report. I think that's going to be a useful tool going forward. Having said that, the actual progress that's been made is not so good. I think that clearly sort of the operational pressures are playing a large part in that. So we're going to carry on monitoring it, but on that one at least, I think we've got a mechanism now for at least tracking status appropriately. So I think good report, not so good content, but at least we've got a way of keeping an eye on it. The other one I wanted to highlight was the one about risk. Paula came along and gave us a really good overview of our risk assurance and the corporate risk register and how it linked, how the risk management processes overall linked with the BAF. It was a very helpful overview. I think there was an assurance level of 5 on that, which was very helpful, and she had a clear view of how we were going to move to 6, which was also gave us additional assurance. Apart from that, I think happy to take it as read. Thanks.
Thank you. Any questions? No? Okay. We note that for assurance. Let's move on to the report of the Trust Management Executive. Matthew?
Yeah, thanks, Chair. Again, a good template from Rebecca, so a pretty straightforward report which does help to link to the board assurance framework and is, I think, quite clear on outcomes. We did have a shorter agenda in January.
because of wanting to make sure the operational teams and divisional directors particularly time was well spent. So fewer items actively discussed, but I think we covered the main ones, as you can see there, and those fed through the governance. So no particular points to note of escalation.
Thanks very much. Any questions, comments on this? I mean, it's good. I mean, one of the things that I think continues to worry me, and I guess others as well, is the scale of your TME agenda. It's huge, and the idea of shortening it and having more, in-depth discussions, it seems to be a good thing, irrespective of the processes we're in. But that's just an observation. In terms of the way it's presented, the only issue that kind of balked with me, and it may be just me, I'm sure Colin will be able to put me right on all of this, is in the sense of when it talks about item, it talks about outcome, and an outcome is escalated to a committee, and I just don't really think that's what an outcome is. I'm not, I assume people don't think that is, the solution, the way you solve these problems. I'm sure that's not the case. I just need it. Am I wrong in this, Colin? Is this your?
Thanks, David. No, I would concur with that. It's something I would like to have further conversations with, perhaps with Rebecca on.
I just think we need to think that through, because the whole point is that we take action to reduce the risk and do things. Not as brilliant as the subcommittees are, they aren't going to solve these problems for you. All right, thank you very much for that. We note that. Any other business? No. Okay. Next Public Trust Board is the 10th of March, 2022. Thank you very much. We'll now move on to a meeting of the corporate trustees of the charity. Right, I've got the right bit of paper here. Apologies, I've got Wakar and Sharon. Anybody else? Declaration of interest on the website. Minutes of the meeting. Are they? Agreed, yes, agreed, that's fine. Charitable Fund Report. Charitable Funds Committee Chair.
Chair. I'll take the report as read, really. Just a couple of things to highlight. One is that at long last we've had the annual report and final accounts sorted. The board will remember that we had to change auditors, so we've successfully appointed Bishop Fleming. They've done their work. They've given us a pretty clean bill of health, just one technical issue around the helipad, which isn't of concern. And we hope to be able to do this in a more expeditious fashion next time round. We've learned from this process, and it will hopefully now become a finely tuned machine. The other thing to comment is on CCLA investments, we had a report in some detail about the good work that those who manage our funds on our behalf are doing, and we were satisfied that we're getting a very reasonable response of both in terms of capital growth and also return on our investment. So I think that's worth noting. Thank you.
Thanks. Anything you want to say about this, Richard?
So first of all, I think. Oh, sorry. You asked other Richard, right?
Yeah. Sorry, I was referring to Haynes, the doyen of the charitable funds.
Thank you, Chair. No, I think Colin has covered the key points. He's right that we are looking to deliver the next charity annual report in a much more timely way, and I think we've already got a process in place for that. But no, I don't have anything to add.
Okay, thanks. Richard Oostrom.
Thanks, David. You're a quick learner. So first of all, I think compliments, because I can clearly see there's a lot more structure to this than there has been in the past. So I think that is really good progress. Secondly, I just have a question. It may be a bit of a silly question, but nevertheless, I saw we funded pizzas for the ED staff, and I think the pizzas for the ED staff are a really good idea. No debate about it. But why are we funding this from this source?
if I could take that, I was at Charitable Funds and I asked the question of the committee whether that would help, whether they would help fund that. If you think it should come from another fund, I'll need to take that back. But that was agreed at the Charitable Funds because the particular night in question, the staff had an awful night, and they were due on again that night. So, and it was very, very greatly received.
I completely get it and sympathize with that, Paula. And I think that is the type of thing we should do for teams that are under stress and in certain situations. But that's a normal part of the business, and usually I wouldn't look for that in a charitable fund environment.
Okay, Richard?
It would normally come out of these funds in any organisation, any health service organisation I've worked from. There's a reluctance to use revenue taxpayers fund directly for this sort of thing. That's why it's just the way things operate. Was it just an accident that they had the meeting while you were looking for pizzas? Or was this done retrospectively or?
No. It was the morning of that meeting. The night before was an awful night, and I just took the opportunity of asking that question on the actual day.
I just think that, what would have happened if they hadn't have met on that day?
Well, I think I'd have still tried to go through a process to access the funding through the Charitable Funds Committee.
So all I'm saying is that should there be a fund somewhere that?
Oh, I see.
These sorts of things. That's all. Richard.
Yeah. So just to pick up on those last 2 points, Chair, the key phrase that we use as a yardstick for measuring the appropriateness of charitable funds or not is over and above the core NHS offer. Now, obviously, on-site catering is core NHS offer. Additional food or anything else by way of a thank you to staff in particularly pressing circumstances is over and above. And in answer to your question about the committee, it was timely, but there is a process by which I and finance colleagues can approve expenditure, and we can also seek chairman's approval from Colin if that exceeds my authority. So there are processes in place where we don't need to take everything to charitable funds, and in fact had it not been the fact that the committee was taking place, we would probably have managed it in that way, but it was quicker and easier to just take it to the committee as happenstance.
Anita.
So Richard has just answered one of my questions, which was about the process for dealing with emergency requests, so that's good to know. Generally speaking, one of the problems we always used to have with charitable funds is that we weren't very good at spending the money we received, and therefore we tended to accumulate. Do we feel that we've now got that in balance, because we must be seen to be spending our donations? That's really important. So that's my first question. My second one is, and I guess it comes back to the pizza idea, do we have any kind of process or any kind of systematic kind of review of teams who may be struggling that we would put in these kinds of offers in? Because what I'm thinking is, okay, ED, Paula happened to know about it, therefore it came to you. But I imagine that, respiratory or ITU or various other people have had issues over the last few months. Do we have a way of picking up teams that are struggling so that we can use that emergency process where we need to? Thanks.
I think Tina wants to come in there on that one.
Yeah, we do have a health and wellbeing steering group where we have representation from each of the divisions on that, and that's where we do update our staff health and wellbeing offers accordingly, and we'll identify additional support to go into those areas such as health psychology, etc. So that's the route that we pick it up, and we take those ideas through the bronze, silver, gold for discussion as well.
Okay, thanks, Julie, and then Richard Haynes.
I'll just quote back Richard Haynes's words back at him. It was quicker and easier to take it to a committee. If ever that's a sentence that stacks up, then the processes are too big and too long. I'm used to a system where that for certain people, certain of the execs have got access to a fund that up to a certain level can do it and do it instantly. So, I mean, I think it would be entirely reasonable for Paula, Tina and Christine to have access to a fund to do stuff like this just on the spot. If it's quicker and easier to take it to a committee, it ain't quick and it ain't easy and it's not fulfilling the purpose.
Good point, Julie. Richard.
Sorry, just to clarify, Chair, I could have approved it, but I was in Charitable Funds Committee at the time I was being asked to approve it. So that was why we asked the question live at the committee. That's why it was quicker and easier, because otherwise it would have taken me until the end of the meeting to approve it.
Okay, but the point about having
sorry, Chair, I had actually put my hand up to respond partly to Anita's question as well,
Okay.
which is, yes, I mean, Tina referred to the health and wellbeing group to flag things. Obviously, it's something that gets discussed by the executive team on a daily basis at the exec hub to review the areas of pressure, and it's also something that we are working. Sophie Burt, our head of community development and fundraising, is working with the divisions on. And what we're trying to also do, as well as having access to general funds, is to support the divisions in rationalising their own funds, so that then they can take that action directly rather than having to come through any kind of process. So, to Julie's point, we are trying to make this as flexible and responsive as possible and leave the decision making as close to those teams who are in need of the additional support as we possibly can. And I hope to make some more progress on that over the next 2 or 3 months.
Great, thanks. Could you answer my other question, though, about the balance between income and expenditure? Are we getting that right now? Because it's something we've struggled with historically.
I think it would be fair to say, Anita, that we're still not spending as much as we would like, and I would like to see the reserves starting to come down. As the profile of the charity improves in the trust, which it has significantly, I think, over the last 12 months, we have seen a marked increase in requests for support, and as the trust's own 12-month and 3-year plans take shape, clearly that will then also help to signpost areas where we can proactively start a discussion between the charity and the trust about what support might be needed. And we have also reported to a previous meeting of Charitable Funds Committee that we've been given some NHS Charities Together funding specifically earmarked for raising the charity's profile in the organisation, and we've got a short-term post, effectively a hospital liaison officer who will be doing that, working with teams to identify what their funding needs are, making sure that the money is spent, and crucially reporting back on the benefits that accrue to the trust as a result. So I think over the next probably 6 months to 12 months, we'll see a much more proactive approach to spending the money and a much clearer reporting line back to Charitable Funds Committee and this board as corporate trustee about the benefits that spending is generating for staff and patients.
Thanks, Richard. Simon.
And just to add to Richard, because I put my hand up to respond to Anita's point about spending, notwithstanding that a lot of the funds are restricted and they can only be spent on certain things, we have talked at length about a spending plan as opposed to all the good work that we're doing on raising funds. So it is in hand, but I think there's still a long way to go, that we actually have a plan in place where we know how the money's going to be spent and we're getting it out of the door rather than just bringing it in as it were. But it's a good point to have raised.
Okay, thanks for all of that. And can I thank Richard and Colin and the members of the board for the work they're doing? Because there's no doubt, if I think about this 3 or 4 years ago, that it's moved on significantly in terms of professionalisation, grip, control, all of that. It's in a different place. So thanks for all the work that people have done on all of that. All of the things that people have described, I think, are important. Having a spending plan, having a proper liaison between the divisions and ourselves, making sure that resources are kind of delegated so people can get on with it locally as well as reporting up. All of that, I think, is excellent. And I'm reassured, I don't know if reassured is the right word, I'm assured by Richard's comments around there are systems in order to respond to short-term requests. But I do think I'd just like the committee to reflect on the idea of having a particular fund for each of the 3 executive directors identified that they can use at very short notice on their own thing. I think that would be a really helpful way of freeing stuff up. But I'll leave that to the committee to decide, Colin. So you'll think about that at your next meeting. Okay. Thank you very much for all of that. That's the end of that meeting, I think. Yes. Yes. Right. That's the end of the meetings in public. We will reconvene at 12:30. The Trust Board then will meet in private. Thank you.